Well, speaking of time, I think that was a really terrific beginning to the webinar. We're now going to shift to episode 2, part 2, section 2, which is on opportunistic infections, including tuberculosis, as well as other co-infections. And to lead us through this section is Dr. Brenda Crabtree-Ramirez, who's from UNAM in Mexico City, the Universidad Nacional Autónoma de Mexico. And I think it's fair to say the
Don't worry.
premier
It's
institute in
okay.
Mexico City, the premier institute for medical care and HIV care in Mexico City. So over to you, and looking forward to this next section. And the
Thank
panelists
you.
are largely the same as what you already have been introduced to. So over to you.
Okay, so can you hear me well?
Loud and clear.
Perfect. So this section was led by Dr. Connie Benson, and it's really a pleasure to present on all the team. It's really important for countries like mine, in which advanced HIV disease is still too common. So this is a very important section for my colleagues here in the region. These are my disclosures. So the first case is this 32-year-old male recently diagnosed with HIV disease with a CD4 cell counts of 45, with a viral load very high, above 500,000 copies, and presented with a history of severe headaches, low-grade fever, photophobia, and confusion. So in the clinic, they did a lumbar puncture, and the opening pressure was of 18, protein of 180, and with a glucose of 35, and with white blood cells high in 100, most of them lymphocytes, and the gene expert turned out to be positive for Mycobacterium tuberculosis, rifampin sensitive, and a cryptococcal antigen negative. So in the MRI study, it shows a diffuse basilar leptomeningeal enhancement and hydrocephalus with no evidence of tuberculosis. So this person was put on a 4-drug standard regimen of anti-tuberculosis. And it started with a high dose of steroids. And after 2 weeks, he has significant clinical improvement with reduced headache and a very good clinical improvement. Also, the CSF analysis after 2 weeks showed opening pressure was lower in 14, with a lower white blood cells, and the protein stayed almost the same, and the glucose was in 50 at that time. So the questions here are the following. When would we start the ART therapy? So ART should be initiated simultaneously with the tuberculosis treatment and steroids. B, ART should be initiated after completing the intensive tuberculosis regimen. C is ART is recommended when TB meningitis is under control based on clinical and CSF improvement within 2 to 4 weeks. Or D, ART should be initiated within 2 to 8 weeks after starting anti-tuberculosis treatment and steroids. So please choose your first one, your more correct one. Okay, I don't know what does the panel wants to discuss here. Maybe I can go to you, Dr. Gandhi.
Sure. So this is, worldwide, of course, tuberculosis is the most common opportunistic condition. So this has really global importance, and therefore there have been some important studies that have investigated timing of ART in people with TB. And people without meningitis, we will usually recommend to start ART within 2 weeks of starting TB therapy, and that's because of a series of studies that showed a mortality benefit, especially when the CD4 count was less than 50. So I think if the person didn't have meningitis, there'd be no question, start with 2 weeks. Now, the reason why meningitis gets a big place in these guidelines is there's been a ongoing debate about this. because in a study in Vietnam, the mortality in people who started early ART and late ART was very, very high, and it was high both in the late ART group and also in the early ART group. And that made people wonder, is it premature? Should we avoid starting too early? I think our panel feels like the consequences of not starting early are in terms of bad outcomes are greater than starting early. And so as soon as that TB meningitis is under control, and Dr. Crabtree showed us that the numbers are getting better, the patient's getting better, maybe underline that significant clinical improvement, that really was important. You know, I think
Exactly.
that's why we endorse that. I think what's clearly
So
wrong answer is to wait for B is too long. That's way too long, and so because that 2 months of intensive therapy, people could have a lot of complications. So yeah.
yes, so I think most of the people put the correct answer, which is C, which is actually what you discussed. But another important group did D, which was previously based on in the previous guidelines, in which, as you mentioned, it was around this clinical trial in which the mortality was not so different within their group. So, what the panel ended recommending was what you just mentioned, that early ART initiation is feasible, but requires very close collaboration between the HIV and the TB clinics and the expertise management of ART. So I don't know if someone wants to add to this, Dr. Bedimo, perhaps. Do you have an additional comment?
Just to reinforce the fact that what we're concerned here about is in immune reconstitution inflammatory syndrome in infections that deal with the CNS. So like you mentioned, here we have meningitis TB, but also there was consideration of cryptococcal meningitis. Those are the conditions where IRIS will be concerning.
Right.
However, just like we have recommended now that we still are in favor of early initiation.
Exactly.
But I think also, Brenda, sorry, also what is also important also is the drug interactions. Also, again, like for cancer or immunotherapy, here also we have really a lot of times drug interactions. Here again, you could use also the drug interaction checker from Liverpool and Toronto. They're really excellent. So just the advice, just use it. You can use it for all drugs you can imagine. And I think this is also a concern, the drug interactions.
Yeah, sure, Dr. Lehmann. So this is really important. Whenever you use rifampicins, the drug interaction is something that you have to be very, very careful.
And you
So,
know, Brenda,
yeah.
I think you said something very important. You know, you have to have close collaboration, close communication with the TB clinic. These patients are not easy to manage, and
No.
they frequently will, you know, you start them on ARTs, they'll start vomiting, and then, you know, the TB clinics will say stop the ARTs, and it really requires a lot of communication and a lot of understanding with the patient that all these drugs may potentially give them side effects, and you're going to have to sort of manage the side effects rather than stop therapy.
Yeah. So without meningitis, I think no one would question that we have to start within the 2 weeks after TB treatment was initiated. However, when you have TB meningitis, then it gets more complex, as you all mentioned. So what about the corticosteroids? I think there was a publication last year about this. I don't know if someone in the panel wants to comment around that, because many people has questioned me around this. I don't know, Dr. Del Rio, if you want to comment around the use of corticosteroids or not. There was a clinical trial in which it was compared to a placebo, which was double-blinded. However, there were some limitations. I don't know if you want to comment around this.
Yeah, I mean, in TB meningitis, we typically will give corticosteroids, right?
Right.
and typically we'll give prednisone, tapered over 6 to 8 weeks. But there is data on the different doses that you can use and the dexamethasone for the management of TB meningitis. And some people think that it decreases the mortality and the inflammation, but not necessarily improves the outcome. So I think there's a mortality benefit, but they may not have any. I mean, there's a short benefit, but there may not be a mortality benefit. And I think that's where sometimes people say, well, there's really no reason to give the steroids. I think the main reason to give the steroids, in my mind, is really to decrease the inflammation associated with the TB meningitis.
Right.
Yeah.
So, and this is okay. Go ahead.
No, I just I completely agree with Dr. Del Rio. Even though I believe Dr. Crabtree was referring to a recent publication that suggested that use adjunctive corticosteroid did not change the survival of people with tuberculous meningitis. But as she was alluding to, there are caveats.
Right, a lot of caveats there.
Yes, so like a quarter of the population in this study was also using open label glucocorticoids. And that's why, given the previous data of using corticoids, we still recommend this as a recommendation in TB meningitis. So this is a point I wanted to make in this specific case. So if you don't mind, we go to the next case. The next case is of this 26-year-old man, originally from Brazil. He presented with initial evaluation after being diagnosed with HIV during his routine testing. He was at that time asymptomatic, but no past history or prior opportunistic infection, with CD4 cell counts of 540 cells and a viral load of 120,000 copies. In his routine screening for latent tuberculosis, turned out to be positive, the interferon gamma Telens assay, but with a normal X-ray. And he denies to have any symptoms of active TB. So you explained to this patient that he has to be treated for latent TB. So this is the options we have. Which of the following regimens do you recommend considering both antiretroviral therapy and latent tuberculosis infection? A, ritonavir-boosted protease inhibitor-based ART with rifampicin and isoniazid. B, a dolutegravir 50 milligrams once daily and once weekly isoniazid and rifampicin. C, rifamycin-based treatment is not recommended, so daily isoniazid for 9 months. Or dolutegravir 50 milligrams once daily regimen with daily rifampicin and isoniazid. This is a tricky one, so please give me your most correct option. Okay. Wow. Very good. So I don't know, Dr. Gandhi, if you want to comment on this one.
Yeah, so I would say that in the last 2 years, there's been really an explosion of studies on this issue of dosing of drugs with TB therapy. And again, it's not a moment too soon. TB is such an important problem, including latent TB. So there are data now supporting the use of once daily dolutegravir when given with what's called 3-HP. The H here stands for the isoniazid and the P stands for the rifampicin. This is 3 months of weekly isoniazid and rifampicin given once a week. And new studies have shown that once daily dolutegravir is fine. The reason why D is not correct is that with daily rifampicin isoniazid, so-called 1-HP, 1 month of daily rifampicin isoniazid. Right now, the data are maturing. We'll see it. They may change in the future, but right now, the guidelines panel, as well as other experts, recommend twice daily dolutegravir because the rifampicin is lowering the levels of dolutegravir. So that's, the the B answer is a relatively new answer, and I commend the 63% of you who got that, and I think this is rapidly evolving. So, but for today, I would say B is the right answer.
Yeah, absolutely. So this is new data. This is exciting, and so the other thing I want to add is the option D, although it's very not. I mean, it's still pending for if robustness of this data, but also that this dolutegravir giving in this study, the dolutegravir giving twice daily had a better level of concentration, and it had to be given in this study for 14 days after stopping the rifampicin and isoniazid because of this decrease in the concentration. So we have to keep this in mind on the loop. So and see if there's more data coming up. I don't know if Dr. Bedimo or Dr. Carlos Del Rio wants to comment or something additional to this new options that we have as a latent tuberculosis treatment.
Well, I mean, I think you could probably comment more, Brenda, in the sense that you know, while this is a good approach and we put it in the guidelines, most of the world does not have rifampicin, right?
Oh, that was my next comment to do.
And
so
that,
exactly so.
And
exactly.
therefore
we don't have rifampicin. So
yeah, most of the world does not, and that's why these guidelines are also going to be different from, for example, WHO and other guidelines. So while with guidelines, and I think, I don't know if we said this at the beginning or not, but they're primarily geared to providers in the US, Canada, Europe, and resource, you know, sort of not resource limited countries. They're good guidelines if you can implement it, but some of the things you may not be able to implement because you don't have the drug.
So in countries in which you have the highest burden and you will find more people with latent tuberculosis, you don't have the options to give rifampicin, but the data is this one, and that's the recommendation. So
Correct.
For active TB, dolutegravir twice daily is still what the panel recommends. And also efavirenz is an alternative choice, although efavirenz is not a preferred alternative that we give. However, there is many clinical trials performed in this context, so perhaps this can be an option if you don't have available dolutegravir, for example. And also there is ritonavir boosted PI with tenofovir and FTC if you have access to rifabutin, and again, this is not something that we have available in regions like mine. So going to the next case. Oh, I was missing this. So what would be not the treatments that are okay to use while on TB treatment because of drug interactions? This is a list of that the guidelines put: doravirine, elvitegravir, cobicistat, CAP, LA, rilpivirine, LA, etravirine, and rilpivirine alone. And also, there's not enough data to recommend dolutegravir with lamivudine while on rifampicin. So something that it's new but less robust in terms of data in coming up is the use of bictegravir-based regimen while on TB treatment. I don't know if someone from the panel wants to comment on that, but there was a study presented at CROI this year that the use of bictegravir FTC-TAF twice daily with rifampicin-based TB treatment show effectiveness. Most people were undetectable at week 24, and the concentration indeed were reduced, which was one of the concerns, but all remained undetectable, and there was a safety profile and no treatment discontinuation. So this is something we have to have in our radar, that it might be feasible to use bictegravir, but still more data is needed. So we can go to the third case, and this is the last case from my section, is this 36-year-old patient that presents with a 2-week history of headache, photophobia, intermittent fevers, and new onset of confusion. He has diagnosed with advanced HIV with very low CD4 cell counts in 22 cells and a very high viral load. His lumbar puncture revealed an opening pressure very high in 28, and CSF showed white blood cells of 40, proteins in 120, glucose in 28, and he has a very high titer of a Cryptococcal antigen. And in the CSF, in the blood culture, it was confirmed in their cultures Cryptococcus neoformans. So this patient has a cryptococcal meningitis, and he received the induction therapy of liposomal amphotericin combined with flucytosine and fluconazole. Serial therapeutic lumbar puncture were performed to manage elevated intracranial pressure. And after 2 weeks, his headache resolved, and repeated lumbar puncture showed no isolating anything in the blood, in the CSF cultures. So with that, the question to the audience are the following: when would we start ART therapy? It should be initiated at the same time as the induction antifungal therapy. ART should be initiated within 2 to 4 weeks, with earlier initiation at 2 weeks. For those who have clinically improved, have control of intracranial pressure, have negative CSF cultures, or C, ART should be initiated within 4 to 8 weeks, or D, ART should be initiated within 2 weeks. Okay, most of the people got it right. So I don't know if someone from the panel wants to comment on the responses of the audience.
So this is a tough one, right? I mean, again, because here your risk is obviously increase intracranial pressure, and if you have close management of your intracranial pressure, you may start therapy early. If somebody doesn't have high intracranial pressure, you may start therapy early. We want to start early, but you don't want to get in trouble. So, you know, I think 2 to 4 weeks is fine. I think if the patient is improving, you know, earlier at 2 weeks, that's totally fine. I wouldn't wait more. I wouldn't wait longer. And I think, you know, I wouldn't say initiate therapy in everybody at 2 weeks. I think that's probably not, you know, not the right thing to do, and will get you in trouble.
Yeah, so this is important, Carlos. The thing is that most of the data that we have from not deferring ART after 4 weeks or after 8 weeks was performed in clinical trials in low and middle income countries. And that's not necessarily the case for many other contexts. So in high income countries, it hasn't been proved that this deferring the ART is something that is of benefit. So perhaps in those who have really low CD4 cell counts and are responding well to the management and approach of the cryptococcal meningitis, it should be discussed that if it's feasible to initiate earlier than it was recommended before. I don't know if Dr. Gandhi wants to comment on this one.
No, I think Carlos said it right. You know, not everyone, but if you have good control of the intracranial pressure, that's where, you know, waiting too long could get people into trouble because of the vulnerability. I think in places where there was not such good monitoring of intracranial pressure, often because of resources, that's where kind of the longer periods of time came from. There was an observational study that I think you were touching on that suggests that when you monitor pressure carefully and get it under control, that about 2 to 4 weeks. And as Carlos said, if they're struggling to get control, if the cultures are still positive, that's what would take me over to 4 weeks. If their cultures are clearing, their pressure is controlled, clinically they're better. That's probably the first and foremost. That's where you can go a little closer to 2 weeks.
Exactly. If you don't have available a good lab to have isolated cryptococcal, or you don't have the ability to do a lumbar punctures, then perhaps this is not the best way to go. But if you have those all the infrastructure and all the requirements to monitor adequately your patient, and he is doing well, there's no reason for waiting so much. The other thing is that although patients appear without high intracranial pressure, lumbar puncture is still needed. So there's something that we as clinicians have to advocate for, because the high pressure can be shown 3 to 5 days after diagnosis. So this is important for the benefit of the patient. I don't know if someone else wants to comment on this.
There are some questions on this, so maybe we'll begin to transition, and some of the panelists might want to comment on the questions, if that's okay. Is that good?
Sure.
Q&A session, here we are. In fact, we'll stay with crypto for a minute. There are new data supporting the use of single-dose amphotericin followed by high-dose fluconazole. Do people think that the same rules apply in terms of when to start ART? I might start with you, Dr. Crabtree, since you've been leading this. That single-dose regimen, which we're occasionally using now, high-dose amphotericin followed by high-dose fluconazole, same considerations around ART start 2 to 4 weeks?
I think the principle is more likely to be around the capacity that you have to monitor and to have the infrastructure to have a good lab and the monitoring of the patient. It goes more around that than on the treatment itself. If the patient is well monitored and it's doing well, I think it's something that you can discuss within the team that it's approaching and caring for this patient. I don't see a reason why not. If you ask me, in my practice, we see a lot of cryptococcal meningitis, but we don't have flucytosine, so we cannot use this therapy. So I'm not experienced at all in having using high dose amphotericin with flucytosine and fluconazole. So I don't have experience. However, I don't think there's a reason why not, because it has to do more with the how the patient is doing and how well you can monitor the patient that with the treatment itself, in my opinion. But I wonder if someone else has.
I agree. I don't know, Raj. We see a fair amount of cryptomeningitis still here in Atlanta, and I haven't done it. I talked to my colleagues the other day about the single dose therapy. They rarely have done it, and the main reason is the bunch of pills the patient has to take afterwards, primarily 5-FC and other things. So they haven't done it, and they just go ahead and do the standard therapy that we've been doing. I think one thing we haven't talked about, but I think it's also mentioning, is a patient that is asymptomatic. You do a cryptoantigen because their CD4 count is less than 50. They have cryptococcal antigenemia, but they're asymptomatic. And in those circumstances, we recommend you do an LP. If the LP is negative, you start therapy right away.
Yeah, this is absolutely so critical and important, Carlos, because you can prevent for a cryptococcal meningitis, which in the best scenario, it still has a very high mortality.
And I remind people that
absolutely important.
That the best OI prophylaxis, the best OI preventative therapy is called antiretroviral therapy.
Yes.
No, it's early diagnosis, Carlos.
Yeah, correct.
Carlos, it's important to mention that that's just for
Mike, we can't hear you. You sound like you're underwater.
I was just saying about fluconazole that you'd use that in the setting of non-meningeal crypto.
Right.
You treat,
Right, absolutely.
Sure.
Let's begin to move on. The steroid gets a lot of discussion. Maybe someone can comment. We talked about steroid therapy and TB meningitis. I thought that was a really sophisticated discussion around the limitations of the trial that questioned the use of steroids. I agree steroids should be used in TB meningitis. What about in other CNS infections? Could anyone comment for either crypto or toxo? Your approach to steroids for crypto and toxo? When do you use it? Or if
So
at all?
So there is indeed a clinical trial in cryptococcal meningitis in which it was proven that it was not of benefit using steroids. However, it has been used, for example, for a pulmonary active TB, and it has been used for preventing iris in those who have very low CD4 cell counts. So I have had experience with that, and it's a low dose. So in this context, steroids is something that we use on regular practice. It's a study that was led by Graham Manges. However, in cryptococcal meningitis, as far as the data that we have, there's not benefit of using it.
And that point, that was the New England Journal of Medicine paper, a randomized study of cryptotherapy with or without dexamethasone, and there wasn't a benefit. For toxo, I would usually use it if there's a midline shift. I don't use it preemptively, but if there's midline shift, then for toxoplasma.
I mean, you would use it like you mentioned, Raj, you would use dexamethasone to manage the intracranial hypertension, and as if you would manage any intracranial hypertension, but it has no benefit in the adjuvant therapy of cryptomeningitis.
Yeah. I also agree with Raj. For toxo, it's a different story. I know that corticosteroids have been looked at management of several CNS infections, including cerebral malaria. Most of them, they have not been found to be useful, but toxo, it's a little bit different. You know, some people say that if your protein count is very high in the CSF, corticosteroids may be helpful in the setting of toxo. But I agree that the recent evidence for crypto meningitis does not support adjunctive use of corticosteroids.
Right.
We're going to need to shift to our next section, but I'm going to try to get one more latent TB drug interaction question in, and then we'll go over to Dr. Springer. So maybe for you, Dr. Ramirez, you showed us that with 3-HP, the weekly rifapentine isoniazid, which one of our participants comments is available in their setting in Malawi, so it's sporadically available. Do you think that you can give bictegravir with 3-HP, or do we just not know the answer because it hasn't been studied?
So I guess we don't have the answer. That's the most safe way to answer this question.
Yeah. I think the data has now emerged well for dolutegravir, but even though we saw some data, as Dr. Crabtree showed us with bictegravir with rifampin, we don't have it with 3-HP. I agree. I would steer clear of that. It's not in the Q&A, but one of our attendees from Chicago is asking about using cabotegravir rilpivirine. This will be our last question for the live. Cabotegravir rilpivirine with 1-HP, and I think on your slide you said cabotegravir and rilpivirine both can interact with rifamycin. So is that something to maybe try to avoid?
Yeah. So this is not recommended, and it's shown in these current guidelines because of drug interaction. So it is the concern that the levels will be not enough to be effective. So for now, with the data that we have, because of this potential interaction, it's not recommended.
I'm going to give Dr. Crabtree a break from talking, but I might ask you, if you don't mind, there's a couple of questions in the chat, if you don't mind.
Sure.
And many of them are on this topic, but we're going to turn things over to Dr. Sag, who's going to introduce our next speaker.